pharmacology class. Susan Greider back again to finish up our respiratory section. And here we're going to talk about minimizing the need for oxygen. And when we think about our drive to breathe or why people breathe, a normal person will drive, or a normal person's drive to breathe comes from the brain stem, and that drive is enacted by the need to blow off carbon dioxide. So carbon dioxide builds up in the bloodstream. This acid builds up in the body. Our brain says that it doesn't like it. It decides that it wants to get rid of the acid, get rid of the carbon dioxide, and therefore we breathe to actually blow off carbon dioxide. But what happens when you have a COPD or a patient who retains carbon dioxide? When that happens, they are always at a higher level of CO2. They are always a bit acidotic. Therefore, if you give a COPD patient or a CO2 retainer patient oxygen or too much oxygen, their body breathes to obtain oxygen, not to blow off CO2. So if you give them too much oxygen, their body and their brainstem thinks, oh, I have plenty of oxygen, and will actually stop breathing. You will put them into respiratory failure, and again, they will stop breathing. So that is one reason to think about why we need to minimize the need for oxygen and only give oxygen if needed in a COPD patient or a retainer patient. In a normal patient, it's okay to give them oxygen. You're not going to hurt them. But in someone who retains retains carbon dioxide or a COPD patient, you have to be very careful in how much oxygen you actually give them. So I'm going to move on with this. Some things that limit the need for oxygen: if you keep them calm, if you treat their pain, as we discussed before, treat their fever, not only with Tylenol and ibuprofen, but think about cooling blankets, ice packs in the groin and axilla, just turning the temperature in the room, taking the blankets off of the patient, taking lots of heavy clothing off of the patient, and spacing activities with rest. And I think about a little elderly man with end-stage COPD that I am a surrogate for, and I think about how he has to do his activities. And we've actually done continuous pulse ox on him for multiple days in a row and found out when his best time or his highest O2 sats are. And that would, for him, is in the morning about 45 minutes after he's had his morning meds. And he gets about a 2 to 3 hour window where he actually gets his sats up until about the mid-80s. And when it gets into the later afternoon and in the evening, he drops into the very low 80s and even into the high 70s. When his sats drop below 80, he does not function. He can't eat. He has trouble speaking. He has trouble just getting to the bathroom. So think about that. So if his pulse ox is better in the morning, what would I do to space his activities? I need to think about him eating during that window. If he's going to bathe or do any ADLs, it needs to be during that window. He also may need to rest and recover and come back and finish the activity later. So maybe small, frequent meals because they don't have the energy to eat. Maybe bathing part of the body in the morning, part of the body a few hours later. Whatever works for that patient, but again, they may need rest in between activities. Talk about oxygen. Itself here is an oxygen tank. Some things to remember about the oxygen tank. Of course, it's going to need a regulator. This little green thing at the bottom on the right is just called a Christmas tree. It goes on the bottom of the regulator and allows the oxygen tubing to connect to the regulator. Just some different pictures of oxygen bottles. All oxygen bottles must be in a carrier. They are never allowed to be placed in a patient's bed. They are never allowed to be transported in a patient's lap, as in a wheelchair. It's often seen, but it is a missile. If that regulator comes off or the top of that bottle comes off, it's a bomb. It's a missile. It'll go through a wall. It'll go through an MRI machine. It'll kill a patient. Therefore, you need to just always make sure that it is in a carrying stand, not with your patient in the bed or in the patient's wheelchair. We're going to talk here about different oxygen levels and how much do they actually get from different devices. Say a nasal cannula versus a Venturi mask versus a simple face mask versus a non-rebreather mask. And there are some slides listed for you here. I'm just going to clip through these real quick, and I'm actually going to show you where I actually gave you a video, and I actually sent that video to you several days ago, or maybe a week or so ago, and it is in your homepage. Flip here. If we go to your Blackboard and when you look at your announcements, and I scroll down in the announcements, there we go. Open that up. We're in here. Here we go. Under your announcements, if you scroll down through your announcements, here it says oxygen delivery. Also has some of your respiratory meds in links that you can click on. But we're going to go ahead and watch that video real quick. The only difference in that video that I would remind you is we don't call them nasal specs, we call them nasal cannulas. Now let's go back to our PowerPoint. And again, there you have your nasal cannula. At 1 liter, is 24% oxygen. At 2 liters, it gives 28% oxygen. Do remember that room air is 21% oxygen. 3 liters, 32%, 4 is 36, and 5 is 40. And there is your Venturi mask that was discussed in the video. I think the video explains it a little bit better. You also have a simple face mask as well as a non-rebreather mask, right? Okay, so there's your simple face mask. When we're thinking about oxygen, some signs and symptoms of someone who is hypoxic is confusion, restlessness, dyspnea, declining O2 saturation. Their heart rate may increase as well, and this may signal the need for intubation. If we do intubate someone, they will generally be sedated. They will be sedated so that they don't fight the tube, as well as attempt to rip it out. Intubation not only allows us to deliver higher amounts of oxygen, it allows us to deliver PEEP, it also allows us to protect an airway. Protection might be needed if someone is seizing, if someone is vomiting, if there is blood in the airway, foreign bodies, or any type of purulence draining down into the lungs. This would be a good way to, again, protect the airway. So now that we've talked about the need to give O2 and minimizing oxygen, let's talk about the support or work of breathing and what we do to position the patient. So to prevent decompensation, we want to position them for ease. So in other words, use gravity. That means elevate the head of the bed. So we would put them in semi-Fowlers to high Fowlers. If a patient, like my little friend that I'm a surrogate for, is having a really bad night, he won't even be able to lay in bed. He will actually sit up on the side of the bed and will not be able to lay back. He won't even be able to tolerate high Fowlers. And these people will actually lean forward. They'll get so exhausted. So a good thing to do is actually give them a bedside table so that they can actually lay forward, put their head on the bedside table to get some rest. They just get so exhausted. Another thing to think about is they call it breathing in the roses and blowing out the candles. That's just something that this particular book uses. But what that is breathe in through your nose slowly and breathe out with that pursed lip breathing or that PEEP we talked about earlier. Okay, and there it is again. Slow nasal breath in for expansion and pursed lip exhalations on the way out, and that not only facilitates outflow, but it helps keep those alveoli open and from collapsing. Equipment or respiratory muscles to sustain the work of breathing. So you want to support nutrition. If they can eat, we need to make sure that they can. What can they eat? Maybe if, like my little friend, he can't tolerate eating very well, maybe a supplemental shake might do, maybe some protein supplements, something. Watch electrolytes and hemoglobin. If they have no hemoglobin, they can't carry the oxygen. Advocate for RXs when needed. That's for your asthma patient. Think about that. If they're using their albuterol inhaler 6 times a week, then we need to put them on maintenance medication. We need to be calling the doctor and saying that they need more. If they're on something, maybe it's not enough. Maybe they need a higher dose. Prevent fatigue. So again, space your activities. Prevent atrophy. Coach spirometry. And spirometry is actually, I don't know if you've ever seen one. You will see them when you're in funds. You will see them when you're in nursing 1. That's a little breathing exercise machine in which you actually have to work on breathing in. And it's a tool to teach the patient how to get air into the lungs as well as out of the lungs. So it is kind of like a workout or going to the gym for your lungs. Causes of respiratory insufficiency. We're going to revisit some of the things we've already done. So again, respiratory depth is affected by the lack of CO2 to respiratory muscles, fatigue, restriction, or obstruction. So fluid or air in the pleural space is certainly going to reduce the depth of your respiration. Abdominal distension is going to invade that respiratory cavity and not allow you to get a full breath. Any type of diaphragm paralysis would certainly cause an issue. Even pregnant women may be short of breath, maybe someone with cirrhosis of the liver who has ascites, even just a very large obese abdomen could be an issue. Pain, talked about that, it's going to increase our workload, decrease our cardiac output. Fluid in the alveoli, maybe with CHF, or maybe someone has aspirated, then that fluid is not going to allow the oxygen exchange. Asthma is a problem with what? It's a restrictive problem. We can't get air in. If we can't get air in, we can't get oxygen in, it can't exchange. Degenerative neurodiseases. So what are some degenerative neurodiseases? We think of ALS or Lou Gehrig's. Guillain-Barré causes paralysis. Guillain-Barré goes from your toes up. And if the respiratory muscles are paralyzed, then this person will need to be intubated and on a ventilator. There is MS. There's also something called myasthenia gravis, which is also a neurodisease, but it goes from the head down, the opposite of Guillain-Barré. They're different diseases, but one goes from the toe up and one goes from the head down. But they can, again, paralyze the respiratory system as well as other muscles of the body. Fatigue from prolonged heavy work to sustain the oxygenation, especially like your COPDers, your asthmatics, they will just get so exhausted that they stop breathing. Let's move on. Here is just inflammation of the myelin sheath. So here is a normal myelin sheath, then it degenerates, and then we have edema in the myelin sheath. And myelin sheaths wrap nerve endings, and this is basically what's going to stimulate our muscles to breathe. If this is not working, then the muscle's not going to stretch, not going to work, so our accessory muscles aren't going to work, our diaphragm's not going to work. We're not going to be able to expand and contract our lungs, therefore it's going to decrease the amount of oxygen we can take in as well as expel. Another thing to think about is COPDers. Their anatomy, let me go back, their anatomy will actually change. They call them blue bloaters, and the reason is because the diameter of their chest, the AP diameter of their chest will actually enlarge, and they will get what we call a barrel chest, and that's because of all of the trapped air over years and over time. It doesn't exhale, it doesn't leave the body, and it will actually change the shape of their chest. So a COPD patient, they call them blue bloaters because they look like they have truncal obesity, or their trunks look very, very thick. They will have very thin arms and legs, almost like the little stuck-on arms and legs, like they don't match. And they call them, that's why they call them bloaters, but they will also call them blue bloaters because they tend to be hypoxic. Some things that cause interstitial lung disease or with an inflammatory and a restrictive response: dust, silicones, asbestos, miner's lung. So think about your firefighters, your coal miners, roofers in the past. I know my dad, years ago when I was a child, worked on brakes, and most of your older brake drums were made of asbestos. Not so much anymore, but prior. What about the people that worked in glass factories and had mesothelioma and breathed in a lot of the different dust and glass spores? Farmer's lung, mold. They have hypersensitivity to mold. If there's in those grain, I can't remember what they're called, but the things that hold the grain, a lot of times that has mold in it. The barns have mold in them. Toxic fumes, ammonia, sulfur dioxide. What about your lawn care worker who walks right through the pesticides that he's spraying, or the guy that comes out and sprays your house for bugs and they don't wear the respiratory mask? I have a nephew who has a hardwood flooring company, and he uses all kinds of terrible resins. I know when they redid the floors in my home, I had to move out of my home for 3 days because of the fumes, and they had to actually air out my house before humans could live in it. Yet my nephew works with these toxic chemicals and refuses to wear his respirator mask, and he smokes. Chemotherapy, medications like methotrexate. Methotrexate, we think of, it is a type of chemotherapy, but it's not a chemotherapy for lung cancer. It's actually a chemotherapy that is most frequently used in breast cancer, as well as in autoimmune diseases like RA. Oncology radiation, can cause some interstitial lung diseases. We have autoimmune diseases, sarcoidosis, rheumatoid arthritis, lupus, and scleroderma not only affect the muscles and pain, but they can affect any of the organs in the body eventually. So it can affect the eyes, it can affect the heart, it can affect the lungs, it can affect the kidneys. They can all lead to pulmonary fibrosis as elastin fibers and interstitial tissues are destroyed. If we think about cancer, can't seem to move that box. There we go. Okay, cancers, they may show up as unilateral effusions. Things like small cell or oat cell are central and very rapidly growing. Your least favorable prognosis is if you have small cell or oat cell. Again, that central, very rapidly growing cancer. The best hope of recovery is implies a surgical resection, and that's with squamous cell and adenocarcinomas. If they can be surgically cut out and then the patient can receive chemotherapy and radiation, they have a chance at survival. Your oat cells and your small cells, generally, even if we cut them out, they will tend to come back. It does extend their life, but it doesn't usually save it. It will reoccur in general. Centrally located cancers tend to be non-resectable, and again, those are your large cell, outer lung, and rapid. When we think about cancer, this may be a little early for you, but I'll mention it. It will not be on the test, but it's something to think about so that you understand cancers, and it will come up in Nursing 1. Cancers are staged, and how are they staged? We have stages 1 through stage 4, and stage 1 means it's just a very small spot, and it's only in that organ. Stage 2 means it's a bigger spot. It's still only in that one organ, but it's made it to the outside wall of that organ. When we get to stage 3, it's jumped to the lymph nodes. When it gets to stage 4, it's in 2 or more organs. So, of course, a stage 1 cancer is got a whole lot bigger survival rate than someone that is a stage 4 cancer. So just trying to give you an idea of what we mean by cancer and cancer staging. But again, cancer staging will not be on your exam. Okay, here is just a picture of the brain, and we want to think about the brain stem down here, the pons. Pons is responsible for your respiratory or your drive to breathe. It's the brain's way of telling the body it has to breathe. So if you get a traumatic injury to the brainstem or the pons, you're going to stop breathing. Some other things that can be involved is if there's a cervical injury or a thoracic injury can cause paralysis that will incorporate the diaphragm, the intercostal muscles, and possibly the lungs. The work of breathing, 70% of the work of breathing comes from the diaphragm, and 30% comes from your intercostals, your accessory muscles, and your abdominal muscles. So all are necessary, but 70% again is from the diaphragm. Much of the respiration has to do with positioning for ventilation. Again, we need to sit them up. Semi-Fowlers to high Fowlers, they may even need to lean forward and lean on their bedside table, minimizing the need for oxygen and giving oxygen again only if needed, especially if they are a COPD patient. Traumatic injuries, as I mentioned before, not only with the brainstem, but traumatic injuries to the spinal cord can cause the inability to breathe on your own. So if we have a C1 through a C4 herniation or fracture of the spinal cord, then they will be a ventilator-dependent patient. So think of Christopher Reeves, he was a C2. C1 through 4 will also require assistance with ADLs. They will be a quadriplegic. C5 through C6 will breathe on their own. So when that says independent, that doesn't mean they're going to live independently. That just means that they have the ability to breathe on their own with some assistive devices. If they are 7 through 10, they are independent, but would be paralyzed and will need a wheelchair. C1 through S5 can impair bowel, bladder, and sexual function. Herniated discs are localized symptoms, and if the herniation gets large enough, it can impinge on the spinal cord. Problems that affect respiratory rate tend to be neuro-related. Head trauma, strokes, tumors. You need to elevate the head of the bed. If someone had swelling in their brain, you certainly would not want their head below their feet, correct? That's going to do what? increase the swelling, increase the pressure. And we need to hyperventilate patients with head traumas and strokes and tumors of the brain, and space out their cares. An overdose, reverse sedation if needed. So what would we do with that? If we had someone that overdosed on opioids, we would give them Narcan. Narcan would be the drug of choice there to reverse that opioid. We talked about that a bit earlier in pharmacology. We also talked about if sedation is severe enough and respiratory depression is severe enough from a benzo, we would give Romazicom. Okay, just a picture of the brain. Here's a picture of a bleed in the brain. There's a subdural hematoma, and here is an epidural hematoma. So if you see, this one is between the skull and the brain, and this one is inside the brain. Versus here we have an intracranial hemorrhage. So this picture is just showing you 3 different types of hemorrhages. If it is a hemorrhage, if there is brain bleeding in the brain, it is also known as a stroke, correct? Other things that can happen are infection. Hypoglycemia can cause diabetic ketoacidosis and can affect the brain. Okay, here is something called the Glasgow Coma Scale. This is used a lot in an ER, in pre-hospital, in neuro. And it's just a little way to score a patient to see how cognizant they are. And they get a score of 1 through 4 if they can open their eyes, if it's spontaneous to cause of pain or none, to motor response, how they obey commands, localize, whether they withdraw, decorticate or decebrate, is posturing, which is where if you induce pain, they will curl up, and decorticate is where actually the arms will flex out, and decebrate is, decorticate is towards the core, and they will actually posture in. The arms will posture inward, and if it's decebrate, it's extension, and they will posture outward. Flaccid is the worst, where there is no response. And then there's also verbal response. Are they oriented? Are they confused? Are they inappropriate? Do they not speak at all? Again, we talked about if the brainstem herniates, if that pons is affected, if the medulla oblongata is affected, it can actually herniate through the base of the brain where the spinal cord is attached, and that will not only cause loss of breathing, it will ensue death. Some of the cranial nerves, you actually have 12 cranial nerves that come out through the base of the brain. This will not be on your test as either, but is something that you will certainly need to know in Nursing 1. You do need to know at this point that there are 12 cranial nerves. They do affect the brain. One that you're going to be ever so, or revisit over and over and over again to get very, very ever so familiar with is the vagus nerve, and that is the 10th cranial nerve. Every time you swallow, if you vomit, if you bear down to go to the bathroom, if you have a deep cough, if we suction someone, it can stimulate this vagus nerve, and that vagus nerve decreases blood pressure and decreases heart rate and can actually cause people to pass out. So that is one that you'll see frequently. They call it a vasovagal response. All of the rest of these, again, you will need to know, but not for this test. But again, you may want to keep this slide around because it's going to come back to haunt you over and over again. There are references, and this concludes this section of respiratory for pharmacology. Thanks so much.